I would like to thank organizing committee for giving me this opportunity. Today I am going to speak on Fenronal, its role in cardiorenal protection in DKD, other than our traditional therapies. So before starting this presentation, I'll give tribute to Professor George L. Bakris. He has done maximum work in management of CKD and type 2 diabetes, and we will come to know about his work in my presentation. Starting with the case presentation, this is our routine case of 57-year-old gentleman with type 2 diabetes who visit our clinic for routine checkup. According to him, he is fine, he doesn't have any complaint, and he would like to stay like this forever. His reports suggest reasonably well-controlled diabetes and well-controlled blood pressure, and he has been on standard of care for his glycemic control. He is one of the 74 million adults across India who are with type 2 diabetes, and sooner we are going to will be flooded with type 2 diabetic patient and chronic kidney disease patient. By 2030, probably 100 million adults are projected to be living with diabetes. In our population, the prevalence of CKD is around 48%. That means 35 million people are currently living with chronic kidney disease. And Mr. XY could be one of the 35 million with CKD and type 2 diabetes. Now, why identification of CKD is important in type 2 diabetes? If you can see this large data, if you compare a patient of 30 years without any disease versus a patient with early CKD, the loss of life is around 6 years. And if that patient is having CKD plus diabetes, the life loss is almost 16 years. So CKD has impact on life survival in type 2 diabetes patient. Same is true for heart failure patient. As we know, many patients of our chronic kidney disease patient are suffering from heart failure, and there is an overlap between CKD and heart failure patient. If you see the survival, if patient has combined CKD and heart failure, the 2-year mortality is as high as 20%. So there is definitely impact of CKD and heart failure on survival. Now, what is the impact of eGFR on cardiovascular event and death? If you see, if your GFR is less than 30, the overall mortality is 4.7% and the cardiovascular mortality is 2.9%, and it increases exponentially as GFR goes down. So many patients of CKD patient may not reach the stage of dialysis or transplant. They die because of cardiovascular disease. So we need to identify them early, and we need to do something to prevent their CKD progression. If you look at the routine report of our patient, his baseline GFR is 64, his potassium is 4.7, he is having hypertension and hypothyroidism. So according to this GFR, his CKD progression seems to be very low. So he is at high risk if you look at only GFR. So currently he is on routine standard of care, he is on SGLT2 inhibitor, he is on telmisartan. So currently he is on main 2 pillars of CKD progression. So he is in our traditional therapy of preventing CKD progression. Now this is CKD heat map, and everybody should understand this CKD heat map. KDIGO has come up with a heat map of CKD to know the risk of CKD progression and cardiovascular death. Now this heat map has 2 components. One is GFR and second is albuminuria. So if you do only GFR, probably you are looking at the half picture. So if you look at our patient, his GFR is 64. So according to this heat map, he is in green box. That means he is at low risk. But if you do his urine albumin creatinine ratio, which is 352, that means he is in moderate, he is in severely increased albuminuria. He is in category A3. That means now his risk of cardiovascular disease and overall CKD progression is high. He is now in moderate risk. So albumin creatinine ratio has to be done in each and every patient to know the exact box in which patient fits. If your patient is in red, your aim is to drag your patient from red to somewhere here. Now, what we can do for this? CKD is underdiagnosed in patients with type 2 diabetes because of underutilization of recommended CKD screening. This is a large database in which they found that 85% of patients had eGFR assessed during the 15 month, but only half patient had urinary albumin creatinine ratio assessment. So I urge all of you to get spot urine albumin creatinine ratio in all of your type 2 diabetic patient. Now, why albuminuria is important? Because albuminuria and fibrosis goes hand to hand. This is the natural history of diabetic kidney disease. This is hypofiltration stage, then comes so-called microalbuminuria or the A1 stage of albuminuria, and at that point of time generally the hypertension starts to appear. And the worsening albuminuria is generally reflective of kidney fibrosis. So if you do kidney biopsy in this kind of patient with worsening albuminuria, you will see more and more fibrosis. Now, why albumin creatinine ratio is important? It not only early predictor of chronic kidney disease, but it is the marker of CV outcome. If you can appreciate, if your albumin creatinine is less than 30, the patient is still having no albuminuria, but still all-cause mortality and cardiovascular mortality goes high. So albumin creatinine ratio we will tell you about the overall inflammation. So you need to get albumin creatinine ratio in all patients. So guideline recommends both eGFR and urine albumin creatinine ratio testing at least annually in all patients with type 2 diabetes. And ADA, KDIGO and ACE guideline recommend not only to properly identify stage and monitor CKD patient, but to know their CVD risk assessment also. ADA2023 guideline recommend reducing very high albuminuria level to slow CKD progression. According to this guideline, you need to do something to reduce your albuminuria by 30%. So how do we take care of patient like our patient? So traditionally, now there is a concept of 3-pillar therapy in diabetic kidney disease patients. Earlier, we had this kind of therapy in heart failure patient. So to optimize risk reduction, we need this multi-drug therapy, which is 3-pillar drug therapy, along with our standard of care like glucose control, blood pressure control, lipid control, smoking cessation, proper nutrition, and regular exercise. We all are aware of our 2 pillars like RAS inhibition and SGLT2 inhibition. I will speak on non-selective mineralocorticoid receptor antagonist, which is our 3rd pillar of retarding progression of CKD in type 2 diabetic patient. Now coming to the pathophysiology of chronic kidney disease in type 2 diabetes. Basically, CKD and cardiovascular disease in type 2 diabetes is because of these 3 factors: hemodynamic factors, metabolic factors, and inflammatory and fibrosis factors. These 3 factors put together lead to tubulointerstitial damage, inflammation, glomerulosclerosis, mesangial expansion, and glomerular hypertrophy, which leads to CKD progression, while myocardial fibrosis, atherosclerosis, vascular stiffness, calcification, and ventricular hypertrophy leads to CVD progression. Now, we have these 2 traditional pillars of our therapy, RAS inhibition and SGLT2 inhibition, which very well target hemodynamic and metabolic pathway. But inflammation and fibrosis pathway is not targeted by this currently conventional therapy. In CKD patient, there is always MR overactivation, which leads to the fibrosis and inflammation, leading to CKD progression and cardiovascular mortality. Now, why we need further therapy? Because we have already RAS inhibition, we have already SGLT inhibition. This is the landmark trial of renal trial, which looked at efficacy of RAS inhibition in CKD progression. And this trial showed that there is 20% of relative risk reduction. You can see there is residual risk. Then came SGLT2 inhibition in 2013. There are various trials, Credence, DAPA CKD, EMPA kidney. But you can see, though these trials were positive, but there was always residual risk. So in spite of being these trials positive, we have to do something to control this residual risk. These are the various trials of SGLT2 inhibition looking at diabetic patient, non-diabetic patient for kidney outcome and CV outcome, and these all are positive. Now coming to the 3rd pillar of our therapy of targeting retardation of progression of CKD in cardiovascular disease. The Finerenone is a selective non-steroidal mineraloreceptor antagonist which block MR overactivation and thus slow kidney and cardiovascular disease progression. So when you have Finerenone, it acts on mineralocorticoid receptor, it blocks it, it reduces recruitment and binding of various transcriptional factors which reduces inflammation and fibrosis leading to slowed circadian heart failure progression and thus gives cardioprotection. Now, how Finerenone is different from currently available steroidal mineralocorticoid receptor antagonists? The structural properties of Finerenone is such it is quite bulky. So, the potency against mineralocorticoid receptor is highest among Finerenone. The selectivity for mineralocorticoid receptor is highest, which showed lesser risk of breast-related side effect as well as sexual dysfunction. There is no CNS penetration. The half-life of Finerenone is only 2 to 3 hours. But because of selectivity of MR receptor antagonism, the once a day dose is enough. There are no active metabolites, and if you can see the effect on blood pressure, it is minimum. Though in various trials, when patients' blood pressure was well controlled, the impact of blood pressure of Finerenone was very low. But if patient has slightly higher blood pressure, definitely Finerenone can reduce blood pressure by around 6 to 8 millimeter of mercury. So the indication of spironolactone and epinephrine is resistant hypertension and heart failure, while indication of Finerenone is CKD associated with type 2 diabetes. Looking at the evidence of effectiveness and safety of Finerenone, after successful phase 2 studies like ARTS diabetic nephropathy and ARTS heart failure trial, which established the safety and efficacy of Finerenone, there come the phase 3 program, which enrolled more than 13,000 patients. There were two arms of this trial. One was Fidelio's DKD, which looked at the renal outcome, and second was Figaro DKD, which looked at the cardiovascular outcome of Finerenone in type 2 diabetes. There is a robust number of patients, and you can see this various trials starting from renal to EMPA kidney. Finerenone program is the only study in which they have taken more than 13,000 patients. So there are robust data which allowed investigator to draw conclusion. Now this is the study protocol. For 4 to 16 weeks was the run-in period, then there was screening period, and then patients were randomly assigned to receive either Finerenone or placebo. The starting dose of Finerenone was 10 milligram, then it was increased to 20 milligram, and then patient was randomized. 7,000 patients were randomized in Figaro, and 5,700 patients were enrolled into the Fidelio DKD. The primary outcome in Fidelio DKD was composite renal parameters. There was time to kidney failure sustained more than 40% reduction in eGFR or kidney related death, while the secondary outcomes were cardiovascular outcome. While in Figaro DKD, the primary outcome were cardiovascular and the secondary outcome were kidney related. And the fidelity in which they have pooled all the patients of this two trial, which is a pre-specified pooled analysis, and here the outcome were cardiovascular composite outcome as well as the kidney composite outcome. But here the kidney composite outcome were stringent. The parameter was at 57% sustained reduction in eGFR, which is like translates to doubling of serum creatinine, which is the best marker to see the CKD progression. And this phase 3 program included patients across the spectrum of CKD severity. Fidelio DKD looked at the late stage CKD, Figaro looked at the early stages of CKD, and the Fidelity looked at overall patients. So CKD stage 1 to 4 were enrolled in Finerenone program. If you see the baseline characteristics and outcome, the Fidelity, more than 13,000 patients were enrolled. And if you see, almost 100% patients were optimal dose of RAS inhibition, right? So it was not like that the patients were not on RAS inhibition and they started Finerenone. And the dose was robust. It was optimally tolerated dose. It was not like 25 milligram of losartanol like that. Though in this trial, the SGLT2 inhibitor and GLP agonist were only 7%. And if you look at the CV endpoint, Though the composite CV endpoint was 14% relative risk reduction, the hospitalization for heart failure reduction was 22%. The composite kidney endpoint was 23% relative risk reduction and the 20% reduction in the requirement of dialysis. There are other cardiovascular and heart failure outcomes in fidelity trial. There was 22% reduced risk of first heart failure, reduced 70% risk of cardiovascular death in first heart failure, and 32% reduced risk of new onset heart failure. After this trial, European Society of Cardiology recommended now the use of Finerenone as a class 1A in heart failure, reduction of heart failure risk. If you look at the reduction of urinary albumin creatinine ratio, over a period of 4 months, if you versus placebo versus Finerenone, there was 32% reduction in urinary albumin creatinine ratio. If you compare side effect of Finerenone versus placebo, the biggest concern was hyperkalemia. But in this trial, though the hyperkalemia incidence were pretty high, but hyperkalemia leading to permanent discontinuation was only 1.7%, and there was no death because of hyperkalemia in this trial. There were various risk factors like high baseline potassium, higher low GFR, a higher urinary albumin creatinine ratio, and concurrent use of beta blocker use associated with higher incidence of hyperkalemia, but there was no death related to hyperkalemia. Other side effects like acute kidney injury, fall in blood pressure, gynecomastia, change in HbA1c were comparable in Finerenone versus placebo. What do the current guidelines recommend? So Finerenone is now approved in India with the same indication as the US FDA guideline to reduce sustained eGFR decline, to reduce incidence of ESRD, and for cardiovascular protection. The various trials, various guidelines have now taken Finerenone as a first-line therapy in prevention of CKD in type 2 diabetes. These are some real world evidence studies. This is fountain studies. I will not go into the detail, but this is the retrospective observational descriptive single cohort study of new user of Finerenone in US. They enrolled 15,948 patients. If you see their characteristics, they were across all ranges of urinary albumin creatinine ratio. And if you see the reduction in albumin creatinine ratio, it was persistent. At the end of 4 months, the reduction was 33%. At the end of 1 year, the reduction was 38.4%. And when you combine SGLT inhibitors with Finerenone, there is a more reduction in albumin creatinine ratio, and the potassium reduction was hyperkalemia incidence was less. Coming to the case of Mr. XY, the role of Finerenone, we can start 10 milligram of starting dose and we can increase up to 20 milligram. To reduce the risk of hyperkalemia, start Finerenone when potassium is less than 5. If GFR is between 25 to 60, use 10 milligram. If GFR is more than 60, you can straight away start 20 milligram. Monitor serum potassium at 1 month, 4 month, and at 4 month interval thereafter. If potassium is less than 4.8, if patient is on 10, you can increase the dose to 20 milligram. If patient potassium is between 4.8 to 5.5, continue the same dose, continue monitoring serum potassium. If potassium is more than 5.5, temporarily stop Finerenone, and then you can restart once potassium reduces to less than 5. So our patient, we started 20 milligram of Finerenone, and after follow-up, if you see the reduction of proteinuria was 56%. So what you have achieved from high risk, now your patient is in moderate risk. So by reducing albumin creatinine ratio in CKD heat map, your patient progression to CKD and cardiovascular disease seems to be less as it before. So key takeaway, the 5 F's of Finerenone. Initiate treatment when potassium is less than 5. Without treatment if serum potassium is more than 5.5. Initiate treatment when GFR is more than 25. And if your patient is on Finerenone, you can continue till GFR is more than 15. Finerenone reduces the risk of ESRD by 1/5. That means 20% relative risk reduction. It reduces the risk of hospitalization by heart failure by more than 1/5. Summarizing, Finrelon is a selective receptor antagonist which is effective as cardiorenal protecting agent in type 2 diabetes. So this is like when I saw the picture of Professor Bakaris, he was the one the idea was Professor Bakaris was to find the cure of CKD in type 2 diabetes. And you can see this chart in 80s when there was no specific therapy of CKD was available. The loss of GFR was 10 mils per year. That means within 5 years, patient will end up in either dialysis or transplant. Then came AC inhibitor. Then came the major trials of renal and irbesartan in diabetic nephropathy trial. In 2013-14, the availability of SGLT2 inhibition and Finrelon. And now you can see in 22, the risk reduction is such that probably per year the GFR loss is 2 ml per hour. So from 10 ml, we have come to 2 ml, and probably in near future, when the fourth pillar of treatment, that is GLP-1 agonist, comes into the, we will see cure of CKD. Thank you.
Thank you very much. Any questions?
Sir, according to this trial, the first potassium to be done after 1 month, and then after 4 months, and then every 4-month interval. Whenever you are changing the dose of potassium, you should get it done after 1 month.
Thank you.